Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. We have a great session tonight, uh, um, brought to you by disasterplasty.org and three of the major faculty about how to avoid disasterplasties. Um, the best way to avoid them in your clinic is to send it to these guys, but that's a separate discussion. I am going to have them introduce themselves, and then we're going to start with John Minter. John, why don't you introduce yourself?
Good. All right. John Minter, Atlanta, Georgia. Um, Practice up here in North Atlanta, actually. And yeah, I see my fair share, sometimes more than my fair share of these problems. So it's great to be here.
Herrick, you want to introduce yourself?
Yep, Herrick Siegel. I'm in the Philadelphia area with Rothman and Jefferson, and I've been doing this for about 24 years now. Seen some very interesting cases over the years that I'd like to share with everybody.
That's great. And Richard, the king of disaster.
All right, okay. I'm Dr. Bush. I'm in Dallas. I'm the director of Dallas Limb Restoration Center. If you notice, we have a bar behind us because if you want to do this for a living, you better be drinking these disasters. I've done this a little bit longer than Herrick and John, so I'm the elder statesman. So I did this way back when we didn't have things to fix these things with, that you guys have now. So maybe there's some things we can teach you here about maybe try to avoid these things and how to deal with them. We definitely deal with this directly in the course we do, but it's more to try to teach you guys to help you here going forward.
Excellent. So, John, why don't you start us off, and we'll
Okay.
get going.
Definitely get that done. Here we go. All right. So, really what I want to do is, sorry, what I want to do is just jump into this. And I was asked to just kind of talk a little bit about the workup. And when I got that topic, this is immediately what I'm thinking about. Because my vision is that every day when I go into clinic, uh, this is kind of what gets presented to me. You get these crazy cases, but it's almost like a tsunami coming right for you. And it gets to be a little heavy at times. But so it's important to, as you take a look at these patients, you really do want to take a look at the whole picture. And so for me, as you look at this on your left, that's more of a 10,000 foot view. On the right, it's more of a ground level view. And so for me, it's like, I just got to ask, why are you here? Uh, and, we get a thorough history. What has happened? What are they seeking? Is it pain relief? Is it functional return? Do they have a history of infection? And if they don't, you still have to worry considerably about that. And then that sort of spot on, view, their surgical history specifically, what's been done, medical, social, health issues. Just, you want to make sure you've got past x-rays, past labs, so you can kind of put all this picture together. One of the other things that's really important, I think it's overlooked a lot, is what is their social safety net? In other words, what's there after this patient, if you decide to operate on them, who's there for them? What's the story on that? Because that can be a real rate limiting step to move forward. They just don't have a means to, they don't have people. And that's a daunting problem, in our aging population. And I got to tell you, I lean heavily, heavily on this. I had a chance to work with George Cerny, and for me, this host classification is critical. The Class A host, that's the healthy patient. Let's say there's a problem, mechanical, in fact, or just whatever. This guy was maybe, or a lady, kind of a weekend warrior type, no health issues. Class B host, there's local pathology, and there's B prime systemic disease. The Class Bs that are both local and systemic, you have to kind of group all these in such a way that you can really break these down, because these are these critical elements as you assess patients. And ultimately, the Class C host, which is sometimes not so obvious, but that's where you really have to take a look. And those are when actually what you would plan to do almost be maybe more harmful to them than, for example, them dealing with an infected joint. So that's just part of how I assess these patients. A, B, and C, that is very important to me. As far as imaging goes, this is just a litany of things that we're all trying to do. And sometimes angiography is really important. And I've got listed at the bottom here MRI, plus and minus on bone scans, but MRI, the technology there has really kind of jumped a lot, and thankfully our hospital system has this now. And this is this new CMAC. We don't have the Maverick because I think we go mostly with Siemens, but so it's basically a metal artifact reduction, but it's really great for soft tissue problems, collateral ligament injuries, looking at dense synovitis, fluid collections. And it's actually superior to CT in a lot of ways and trying to figure out exactly what's going on with these patients. You have to request it specifically. You want to make sure that you do that and talk to the radiologist because this can really help you identify some pathology. And so anyway, I would tell you that that's something that we're actually using more and more in practice, and it can make a difference. As far as ruling out infection, that's like a day-long lecture, but I really do lean on the international consensus meeting. I went to that in Turkey last summer, and it was an amazing meeting. We all learned a lot together and came to consensus about diagnosis and treatment. But the thing is, you've got to figure out what your enemy is. So these are get your standard labs, get aspirations. I do a lot of open biopsy when we can't quite get what we need. Cultures, next generation sequencing, it's all part of it. There's actually a app. It's called the ICM Philly app, and you can download that. And it has all this great information on it that basically parallels what was gone over at that ICM meeting. So that's kind of it for me.
All right. Super. Who's next up? And then we're going to show some cases and we'll
I
show.
guess I'm next up.
All right.
See if we can share that. Okay. So this is something that we talk about, and if you haven't been to some of these quick meetings and things, the guys talk about this stuff all the time. And they no one ever gives you a real answer because it's hard to do that, because it's hard to say no to a patient. And that's one of our big dilemmas. We're all very altruistic and we want to take care of people, but there's times you have to say no, or you say no right now. We have to do this before we can operate on you, and that's the hardest thing to do with the patient. You got to have that. You have to have that heart-to-heart talk with them, all right? Because what can you influence? Now we talk about obesity. If you go over to Europe and they talk about obesity, they're talking to people in their 30s. All right, I'm from Texas. All right, I mean we're talking to people in their 40s. Right? And we're talking about people with BMIs over 40. Right? That's real obesity. That's when you start running into problems, when the complication rate increase. The complication rate at 45 increases. The complication rate at 50, all right, is tremendous, almost 30%. All right. Malnutrition, we've all talked about that. The Academy this year, there were 5 companies selling products to boost your patients up. It's becoming a new thing to do. All right, you got to do it before and after surgery, even on elective people. You don't realize how much a surgery takes out of a patient and how much it can help with recovery. And these are the new things. And we've been talking about this for years now, but now it's come into fruition. And diabetes always is a big problem. Smoking, it's very, very hard to get these people to stop smoking. It's just ridiculously hard to get them to stop smoking. It's near impossible sometimes. And then the alcohol, of course, and the poor compliance. Poor compliance, they did a study, all right, was it 10 years ago or so about compliance. 80% of all patients are not compliant. That was an amazing eye-opening thing. So, and John mentioned they have to have some things at home to help them. You cannot do this without help at home when you're doing these kind of cases. All right. So what can't they influence? Well, their age. Age has a lot to do with it. All right. Soft tissue, blood flow, all right, recurrent infections, chronic infections, tumors, all these things, osteomyelitis, they can't control those. All right. Those things are things we can't control. All right. And sometimes some of these things we got to learn maybe we shouldn't do what we're doing. All right. And some of them we'll go over some of those. All right. So there's multiple studies on dysvascular things. We all know that. All right. People with had muscle flaps and skin grafts and dysvascular extremities, all right, there dramatically increases their problems. Multiple surgical patients multiple things. People that had bypasses. These are all real problems, and they increase your risk with these kind of patients. All right, what are the risk factors of the total hip and total knee? Well, kidney disease alone is 3 to 0.5 morbidity. Dialysis and transplant patients are 50% almost complication rate. There was a few studies a few years back that maybe we shouldn't even be doing total knees on these kind of patients because the complication rate is so high. Rheumatoid arthritis, we all know, chronic alcohol, people with just chronic insufficiency, all right, one or two kidney disease and things have a higher rate. So these are all big problems, all right? What are the risk factors of persistent wound drainage after total hips and total knees? Well, diabetes and morbid obesity have the highest rate of drainage post-surgery. Rheumatoid arthritis, hydrothyroid, female agenda, they all do that. Now, patients with comorbidities, all right, the best reported success rate for homogeneous infection is 71%. And then we talk about, you guys all talk about single exchange. Well, that's great, but there's times you can't do that. Chronic MRI, chronic patients probably should not have a single exchange. All right. Those are usually primaries. I know you had all this stuff from orthocolina, and that's great, but those are not chronic infections. And you can't do a single exchange with fungal. They're the hardest ones to treat. And AOS just reported last year on a giant study on gram-negative and the complication rate with those. So you got to know what your organism is too. All right. And malnutrition, no one ever talked about it. We mentioned it for years. It has a huge complication rate. If you're malnourished, you can't heal. And if you're moderate or severe, which some of your patients are, you don't even know about it, then you got a big problem. All right? They're very, very difficult. Those people need either be TPM, they're put on Clinimax and things here for a while, because to reverse that takes months, and you're not going to do it. And sometimes you have to jump quickly. All right. And this is a big problem. So we talked about that over 10 years ago on one of our studies. And we looked at 88 chronic infected patients, and we corrected all their comorbidities. All right. And we found that we were able to actually save 76% if we solved all the comorbidities we could. We didn't pay attention to malnourished at that point in time. And every one of my amputations and failures were severely malnourished under 2.5. So they couldn't heal anything, and we didn't even pay attention to it back then when I first did this study. Now, every single patient I look at and avoid that. We have very few amputations and things and permanent fusions now with that. Right? So what are you going to do? You can't do case. Here's a patient that comes in, giant open wound, had 5 surgeries. That's an allograft on there in a wound, and someone wanted to do a revision knee on the patient. Okay? You're lucky you can get a fusion on that and save the patient's life. You can't do surgery on this. He's had 11 surgeries on that time. You got to sometimes say no. It's either amputation or fusion in my world. Here's another one, had multiple surgeries. Look how red and shiny it is. Open wounds and draining. You can't save that. All right. You can maybe get away with a fusion or an amputation. Yet he had 14 surgeries, this guy, and they kept putting implant in. And then you get something like this that presents with no extensors, no anything. You get that. That's an amputation. Don't even try, guys. Right? You're going to be doomed to failure. You got to say no. Right? Here's the biggest thing I see in the biggest failure rate. This guy had 3 surgeries by good surgeons. All right, and they kept reimplanting and put him on IV antibiotics, but they missed the forest for the trees. See that bone? See all that elevation? That's osteomyelitis. All right, you cannot implant things on osteomyelitis. All right, we learned this from George Cerny and me and John way back when. You got to treat it like a tumor and you got to excise it. All right, and here's what it looked like at the excision. You see all the holes where there wasn't that big rind on the outside there. That's all the osteomyelitis and periosteal elevation. And that's one that I just had to sit there and put a big spacer, take all that bone out, and then reimplant it later. And this patient was saved. That's a silver prosthesis, one of the few in the country that the patient had, and they're doing great for 11 years later. Here's another one. All right, this patient had 4 surgeries that kept failing, kept loosening. Well, all that bone there is elevation. That's involucrum. All right, that's osteomyelitis. All right, if you keep implanting, you have problems. So we resected it, and I resected to the level. See that elevation there on the periosteal? That's all infected periosteum. You have to resect that all out of there to make this work. All right. So we have ethic and responsibility to treat people. All right. We take an oath and expect a duty to provide care. All right. But we're supposed to do no harm. All right. We have a duty to optimize modifiable risk. Now, everybody, we ask this question, well, do you usually modify? Yeah, I do and things, but everybody admits they'll do a surgery that they shouldn't do. We all do it. All right. We all get talked into it, but we shouldn't because we can cause more harm than good. And we always get that one case scenario, we got away with it. But if you keep doing it, you're going to get in trouble. All right. And the other thing is when the patient comes in, were they treated correctly? All right. If the patient was treated by good doctors and failed, then call that doctor and find out, hey, what'd you do? What happened? Find out why it failed. Because if they did the right thing and failed, why do you think you're better than somebody else sometimes? You're not. Maybe you should look at it a different way. Right? So all these studies have a high complication rate and all these things, and no one stratified this. And we have and went through the literature and stratified everything. We'll present this at Disasterplasty. It's a way to use as a guideline for people here going forward and the complication rate per the literature. It's pretty bad, guys. All right. And so when to say no? BMI of 50, guys, stop. Right? You got to stop. Uncontrolled diabetes, you got to control it. End stage renal disease, transplants and things, you got to be careful. All right. And if they've had multiple surgeries, you might have to approach this a different way, either fusion or amputation. Okay. So when considering surgery with these uncontrolled risk factors, you got these high risk, we offer either permanent fusion, amputation, and maybe some of these 1.5 long-term spacers that we have now. But if they're over 30%, you better do something before you operate. So to pick that patient out, all right, you got to get good at it. All right, you got to say no sometimes. All right.
So this is Rich. I just want to comment that
Yeah.
Disasterplasty Conference is coming up September 30th to October 3rd. You could register at disasterplasty.org. Everyone's going to be there. Rich, I just have a couple of quick questions on
Go.
this. In your experience, some of these complex cases, how long does it take to optimize the patient? From you see them and they have, let's say, 3 of those major, malnutrition. That doesn't happen with 2 week. You don't turn that around with 2 weeks of protein shakes, So
Right.
in your experience, if these people are devitalized, how long does it take you in your
You
practice?
send them to a nutritionist and things, and you can reverse them at the right diet and things, and maybe in 4 to 6 weeks, unless they're severely malnourished.
So 4 to
In
6
mor
weeks.
right, in morbid obesity, all right, you have to sit there. We got the GLP-1s now and things, all right, which is better than going to the fat doctors and have all these bans and things. Because even doing a ban and gastric bypass, you almost had to wait a year anyway because the metabolic problems they had, and also increased their risk. So just sending them to there doing the surgery increases the risk too. You just have to say, listen, you got to fix. So I have patients that come in, and every 3 months I weigh them. All right. And if they're getting down and they're coming down, right, and they're below and starting to get at 45 and below, then I'll operate because most people that will do that will continue to lose weight afterwards. There was a nice study done, all right, now about 15 years ago about patients doing obese patients, okay, and losing weight. And we thought, well, we got to fix their knees and hips so they can exercise. You lose weight only 18% by exercise. Most of it is your mouth. So what happened was the study showed that people put on weight after their surgery because they got to the refrigerator faster. I mean, come on.
Well, I just have a quick question for those guys as well. Do you guys delay any of your surgeries if they're referring a patient to you with an infection or periprosthetic fracture for optimization? Or do you consider that not a reason to delay surgery to optimize for, let's say, nutrition or even smoking? Would you not operate on someone that comes to you with an infection or fracture?
If you got someone that we're talking about elective surgery, let's make a difference. This is elective. There are surgeries that aren't elective. If you got someone sick and got septic and all this stuff, you have to operate. You got no choice. You have to operate. If you
Yeah, and
have
I
the
think that's what
ability to buy time with them and things, then that's what you do always when you can. But there's sometimes you're just forced to do surgery.
John, is there ever a time where you're putting patients on antibiotics and suppressing them while they're optimizing, or you kind of ignore the optimization part of a more urgent problem?
Well, I mean, that's like separate questions. We got
Yeah.
antibiotic and then we got optimization. I mean, if you have somebody with a chronic draining sinus, they've already probably been treated in a whole lot of different ways. It still kind of comes down to really diagnosing it, because what they may have is they may have just a just a multitude of organisms, especially fungus that they've been operating on a lot. So, you know, it, I think you can't afford to be maybe somewhat patient if they're not septic and you're trying to optimize them for somebody like that. But if they're acutely infected, well, no, you can't do that. And again, that moves out of that elective thing to like, oh, we got to fix this. This is an urgent problem. So
Mm.
yeah, as far as antibiotics goes, yeah. I mean, th those people are going to get seen. I mean, right after they see me, they've got to see ID, uh, uh, especially if it's chronic. If it's acute, they're going to get admitted. They're going to get the full-blown workup anyway.
Yeah.
Yeah, a good example of that, if you got someone with a draining sinus, but they're not septic, it's like an old war wound. If you can suppress with antibiotic and you can sit there and treat some of their comorbidities to make it better for them, then do that. But the ones that are sick with this and having a big problem, you have to do it. There's no way around it.
Yeah.
Yeah.
Excellent. Herrick, you got some stuff to show us?
Let me see if I can share my screen. Let me know if do you see me?
Yep.
Okay.
Mhm.
So this is you got to show one of these for the Disasterplasty meeting. It's tradition to show the result of some of these big surgeries that we have to deal with. I'm going to talk about some of the reconstructive options. And I too believe in all the things you guys are talking about with trying to optimize patients. But these kinds of patients, for at least in my experience, get referred pretty urgently. Oftentimes present to the emergency room, and they come in with an X-ray, and the last thing I'm thinking about is how am I going to get his albumin up and stop smoking at that point. So that does become a problem. These are a few of my disclosures. All this starts back when you think about Disasterplasties. We're thinking about how to prevent them, but it really is a lot of it has to do with the biology of the patient, as you guys have already pointed out. And Disasterplasty in general is just like the combination of trauma and infections and joints, and then even oncology thrown in there makes it complicated with a lot of bone loss. So when we talk about it, we're trying to save extremities. It's a limb salvage, limb preservation type of process where we even have osseointegration now with amputations to help patients become more functional. But we have to have these in our armamentarium of trying to deal with this. And like Richard just said, not everybody is salvageable, and patients like this that have developed essentially a stoma with their implant sticking out of their knee probably aren't the best candidates for further surgery. So you get the combination of all the bone loss from whatever trauma, joints, revisions, such of that, and plus the infection, you really get into what we all consider the disasterplasty realm. And then you mix in some multiple comorbidities of the patients, which is very common. And most of them are immunosuppressed from something, disease processes or medications. There's a lot of we kind of skimmed over, the complexity of taking care of these patients, but I think it's important to realize that there's probably no group of patients higher at risk of complications than people who've been revised multiple times, have had good surgeons operating on them, and then get referred for some sort of salvage. And you have to consider nerve injuries, limb length discrepancies, all these different problems I'm listing here, including mortality, which is fairly high in patients who have been reoperated on and infected patients.
Mm-hmm.
And once in a while, you get these patients that come in, and it's like a miracle that they are really not having a lot of pain. And sometimes we'll see patients with a little bit of joint space narrowing and they want disability. And then you get patients that are just kind of complaining of, my limb lengthening, my limb is short and I need a shoe lift. And these are the kind of patients you really hope a lot more of them are out there. And I think one of the things, I think you guys alluded to this already, is that we have to just give the patients reasonable expectations. Like, what is the chance of success? And I don't know how you guys do that. Maybe you have something in the back of your mind where if you don't want to operate on them, you tell them there's a 10% chance of success versus something higher. But I think all of us have our ways of trying to persuade the patient one way or another, including the option of amputation usually discourages a lot of people from proceeding with surgery. But our goal is really to get stable implants that are going to last, efficient surgical techniques, and dealing with such complications as hemorrhage, things of that nature. And we have, like you mentioned earlier, Richard, there's a lot of new stuff out there, and particularly custom implants that are really helpful with 3D printing with triflanges being made pretty routinely now. I mean, there's a lot of companies out there that are very competent and familiar with these kind of implants. There's other ways of doing custom implants. I think John probably has put a few out there on LinkedIn about doing cones and hips for patients with dwarfism and other issues like that are custom made, that are very helpful for dealing and avoiding complications. Bad spacers, I don't know. I see these quite a bit. Maybe you guys do too, but it is complicated to remove some of the well-fixed implants and then trying to put a spacer in. And I will tell you that some of the spacers probably do more destruction than help. The soft tissues contract, heterotopic bone forms around these. It's pretty extensive in terms of surgery, how to get them out. These are patients that have been referred to me in the past with soft tissue damage that it's avascularized, cement molds that are kind of shoved in there last minute.
Mhm.
We talked about morbid obese patients. We do have to follow these patients. We get good 2-year results, but such as this patient who's 5 years out with a broken implant, they were over 300 pounds and the implant itself broke and dislocated. And then there's just bad surgical technique out there. I would encourage someone who doesn't do a lot of this, use a lot of imaging. Put your lead on, make sure you're in the right spot. There's no harm in that. I think I'd use a radiolucent table as much as you can if you're not doing this a lot. If it's your first distal femur or even your 10th, probably a good idea to check some imaging. And as well with trauma, have your trauma partners help you out if it's not something you commonly do. I use a pretty solid, you guys can all comment on this, but I've kind of gone to these like stage 1.5. We're using kind of real implants that are solid, stable. I know these kind of prefabricated molds are still out there, but if you want durable, implants that are in there that patients can use and ambulate on, I don't think these are really optimal for a lot of these patients. I do upper extremity surgery as well. Shoulder infections are equally challenging. They're not very common, fortunately, but there's limited amounts of spacers out there, and these reconstructions can be done with reverse proximal humerus replacements, and fractures can occur, which are really complicated in many of these cases. This is a patient who had metal on metal problems, something maybe you guys see. I don't know what the next generation of problems will be. We're putting joints in younger and younger patients, and hopefully, we won't see significant complications from doing a total joint in a 40-year-old total knee patient. But these kinds of patients can be difficult. You can see on the left side there, constrained liner, mostly due to the fact that there's not only bone loss, but the spine is fused, which is also not uncommon with patients getting multiple surgeries for instability problems. These are some kind of prefabricated spacers. There's other spacers out there for infections that can be converted into distal femur replacements. This is not an easy process in terms of recovery. The patients are really debilitated during the process of treatment, and optimizing them is really difficult. A lot of this upper extremity stuff, similarly, you have muscles attaching to metal and using different kinds of fabricated materials such as meshes to try to get these implants to attach around metal can be a big challenge. And knowing when and where to use these kind of implants is very helpful. There's also radiolucent implants. This is the carbon fiber plates around a periprosthetic fracture with super cables that are also radiolucent. So one nice advantage of that, you can really get a good post-operative visual to see how they're healing. And it's also very easy to use a lot of this material as well for periprosthetic fractures. This is just an interesting case. I got referred to this patient who was completely missing their femur. They came in on a stretcher, had a tibia and a foot, but there was nothing between the tibia and the hip. So after ruling out infection, which they were treated for, and then left kind of like this for a long period of time, was eventually converted to a total femur replacement. These are really complicated in terms of getting the soft tissue envelope, where to put this patient. Without a spacer in there, it kind of closes down the space where the joint would normally be. So this can be a pretty challenging situation. I think leaving bad spacers in, leaving these kinds of patients without spacers for prolonged periods of time can be really detrimental and makes it very complicated for joint surgeons in the future. One of the other things I've had to deal with is complications around elbows as well. And these can be big problems if you're considering doing total elbow replacements, or particularly in patients who have periprosthetic fractures. There's plenty of complications that can occur around these soft tissues. However, you do some cases like this, which is a 15-year out elbow replacement with, you can see aseptic loosening, fracture, unable to use their extremity, and reconstructed with an allograft prosthetic composite, along with this distal humerus replacement. And they were very functional post-op. And you got to do really well with these when they
and action.
when they work with you. You better get a good result, otherwise. So that was her end result. As I mentioned, and I don't know what you guys are experienced with this, but you can get these large, massive metallosis problems where there's basically looks like an arthrogram of metal material throughout the joint. Really becomes a metal on metal problem, can occur in the knee if the poly is broken. There's, again, severely debilitating. You can see where the extensor mechanism was and completely destroyed. I like to show this case on all my Disasterplasties presentations. This was a custom-made implant that was actually like this for over 10 years, and she's 25 years post-op here. And she basically wore a knee brace and had this exposed implant, and completely, not in a lot of pain, but came to me looking for some sort of solution to this. And really, I gave her nothing except to either leave it or do an amputation. And she left it in place, and I haven't seen her since. But I think it's really interesting to see how the body reacts to this, and how it's kind of really developed almost like a stoma. It's like an early osseointegration prosthesis. This was a patient who was sent to me with the exposed proximal tibia, debrided, reconstructed. One nice thing to think about is using a gastroc flap to reconstruct the extensor mechanism. If you are going to do these kinds of surgeries around the joint, very useful procedure is turning the gastroc and reconstructing the extensor mechanism. Richard's got some interesting techniques that he's done with using a wire to hold the extensor mechanism kind of down so it doesn't avulse off the tibia. I think that's really helpful to do as well to protect it. See, once in a while I get referred these patients with post-op with these exposed metal implants that peek out, and you have to kind of move the flaps around a little bit and get good coverage. This is an interesting patient I saw. You guys can comment on this. Patient's history of polytrauma about 7 years prior to this, and had a knee replacement, fixation. The long-standing instability and difficulty ambulating, comes in with diabetes, BMI of 36, unable to extend her knee, using a hinge and brace and a cane. She's been told by everybody that there's nothing to do. So basically passed on from surgeon to surgeon, and a lot of anxiety. I'm sure you guys see this kind of patient with tears, crying, anxious, depressed. And she has these films that she presents with. And this is many years ago, but I think it's an interesting case in the sense that, this could have been dealt with a while back, I suppose, but for some reason was kind of delayed, and this has been going on for a long time for her. So doing the workup, no infection, no vascular issues, and reconstructed with this hinge, and reconstructed her extensor mechanism just by basically doing pretty much a majority of a patelectomy there and reconstructing her patella and quadriceps tendons. And again, these really bad spacers that go in, you can see that's kind of pushing right through the patella tendon. It's particularly important, I think, to protect the patella with something, maybe even put a button back on. But I don't know what you guys are doing for your spacers, but protecting that patella and patella tendon are really crucial. Once those are damaged, it's really knee fusion time. But in this case, there was enough soft tissue, and it was reconstructed with these cones and hinge, and was able to pull enough soft tissue around to get complete closure. And that was their post-op. Oops. Spencer's been doing, I think he's on this call, but Spencer's been doing some interesting stuff along with John and I and others with PEC. And this is a really interesting material that potentially has some antibacterial or at least bacteriostatic properties that can be really created and 3D printed very rapidly to, there's one that, there it is. John is holding it up. It's a pretty interesting material. It's radiolucent, and you can put screws through it. You can mold it on the change it on the back table even to customize it further after it's made. And you can even get many different versions made all at the same time, and then make your decision during the surgery. So it takes a couple weeks to make. You need a CT scan, and this was his reconstruction. But these are actually permanent implants, or can be used as spacers as well. Another example of a girdle stone patient. I don't know if you see many of these anymore, but the girdle stones can be difficult to manage as well. We have different techniques to try to do that, but those can be a challenge. I wanted to just bring this up as a topic, really. Those periprosthetic fractures that occur between implants. So here's one between a hip replacement and a plate. And I think the trauma surgeons are doing more and more plating and nailing, retrograde nailing of distal femur fractures. And I imagine if there's a hip either done or previously done, we're going to see perhaps more and more of these interprosthetic fractures that are really difficult. And I think it's a whole different kind of category of trying to reconstruct these types of patients. I'll skip through that a little bit. But this is one of my favorites. It's just like a ball and a bat, and I went in there, and I don't even, it's really hard. What is the point of that other than just to kind of keep a little bit of space open, but difficult reconstruction. I know there's some new papers that have come out recently about stacked cones. You can also stack augments. I know you probably have seen some of this, but these are augments stacked on top of a cage with a cup into the cage. All this stuff can be done. John, are you doing much of this, or are you just going right to the custom primarily? What do you?
Oh, I like customs. The thing is, though, if you have an acute problem, you cannot wait to fix these people. Now with PEC, the timetable is rapidly accelerated, which is an advantage. But to wait like maybe 2.5 or 3 months for a triflange, that's nuts. You got to help these people quicker than that. So yeah, I agree with what you're saying.
Yeah, and I think if you develop, I have on the slide there, if you develop any loosening of any of these parts between it, it really becomes a disaster quickly with metal debris. It has to really be a solid construct, and most of this is held together by cement, really. This is examples of custom stuff. They've come a long way. You can have the model in your hand during the surgery, putting these things exactly where they need to be.
Hey, Herrick, we're running out of time for questions. Come on.
Go ahead, ask me a question.
Stop showing slides. Let's ask questions.
All right, go ahead. Richard wants a question.
What happened to your 8-minute talk?
All right, Richard, what would you do for this one here?
Okay.
Interprosthetic fracture.
Oh, love these.
You'd have to see what bone you got left. You might need a CT scan. The trauma guys will a lot of times put a plate or double plate that one. To us, most of us would do a distal femur if you got very little bone left on that one. Approximately up there. These are the ones where you have that bivalve problem. If the bone's good enough, there are robust plates that I can do and put up there and do a dual plating to hold that together if that prosthesis is still good. So I can plate that and fix that distal femur one on the side. You can do that. The problem is, and you see this with the trauma guys now, and it's funny, you see a distal femur fracture, and there's nothing all the way up to the hip, but they'll put a rod and plate and screws all the way up in the hip now, just in case they have a periprosthetic fracture above the construct. I don't agree with that if the bone's pretty good. If the patient's osteopenic and old, okay, maybe do that. But to do that, I think is overkill by these trauma guys. I really do.
Anybody using the cone cup, the stemmed acetabulum cup?
Yeah, that's a Lumic. We've done a few of those over the years. It's a salvage procedure. If you have enough bone left by your SI joint, goes right next to the SI joint, not across it, and you got to get good bone fixation. It's not meant to be cemented in. If it's cemented in, it has a high failure rate early on. You can sometimes cheat the devil for 2 or 3 years with that, but it is a great salvage procedure that we should be considered. I have a patient who just had to redo her distal femur for arthritis, had this in, she's had it in there 11 years now. It hasn't moved one iota.
Yeah.
I still remember saddle prosthetics.
This is a custom one, and I've been I use a constrained liner for a lot of these. I think it's really hard to get the stability back, but I've seen many of the cases that people are able to get stability from these, and
Mm,
They're also kind of off the shelf as well. John, I know you've done some of these intercalary implants.
lots.
What's your indication? I probably already know the answer to this, but
Yeah,
what's your
well, I mean, massive bone loss, little to no extensor mechanism. When I put these in, I really want to care. I really hope these things last a very long time. I've got a couple out there right now that we're moving to convert. The idea is if they're infected, we got to get them clean. We got to establish that. And so I'll take them back. We'll monitor all their labs. We'll do, I'll aspirate them, send them for next gen sequencing, make sure it's all clear, then start the process. And a lot of times I'll have a company like Link do a silver coated implant. Signature has a silver coated implant. I guess there's more companies than that, of course, but those are the two that I would probably lean on for silver coated, hinge or just convert into a long term fusion construct. But hopefully hinge for most of these. Take them back. It'll be a limb salvage type. But still, that's the way to go.
Rich, are you a silver believer? Are you using silver still, or you're
You do know that I put more silver
I know you
prostheses
do.
in than anybody in the country.
But are you still
Uh,
doing it?
and the problem, no, the problem is getting it approved and through the FDA and things. And the
Yeah.
cost of it is amazing. You got to get it takes a long time to get it going through, and a lot of the hospitals, the one I work at now, it's not cost effective for them. You have to it's got to be absorbed by major institutions and things. We've done 27 silver prosthesis. All right, only three have failed for infection. We do have three people with Agira, which is kind of a bluish of the skin that's around that area that happens, but it's no harm to the patient, and they've done pretty well on it. Most of them are still in there. A few of them have failed eventually because of the locking mechanism. We had to go in and change the locking mechanism, but there's still no signs of infection in those. They've done very well. So it's another alternative for you going forward. It is not to treat infection. You got to clean up the infection and put it on, and it's to prevent from infection reoccurring and stop a biofilm.
Yeah.
I,
Yeah.
I just want to add that it's not a substitute for proper infection management
Right.
techniques. It doesn't replace anything.
Now,
It's
you got to get rid of the
efficient.
infection and then use it. You cannot use it to treat infection.
Yeah,
What do you think about tibial nails? I see some of these come by from time to time. Looks like they kind of destroy the bone to me, but is that still acceptable to throw one in, or do you think
Yeah,
that's
if for short term, maybe if you get a longer stem, but something like this is doomed to failure. One twist, one turn, and you got a disaster on your hands. And so, I do a lot of fusions temporary. We use Link a lot. I've
yeah,
probably done more fusions than most people. Me and Janet Conway do a lot of these. The patient can stand and walk. And what you guys don't understand, you put these articulating spacers in tissue that's swollen. Well, the tissue stays swollen from bending back and forth and stays irritated. When you do a fusion, all right, it lets everything settle down, lets the tissue, the swelling, everything subside over time, and then you can go back and put something in. So there's something to that that allows the tissue, and you can use it's a perfect 1.5 procedure to do, especially if your tissues and everything are compromised. It's better than an articulating spacer. All right. For primary infections, articulating spacer and things are fine. For chronic infections, you got to let these things settle down. All right. You got to do something different than was done before that failed.
Mhm. Yeah.
what about for customs? You guys have a pretty go-to formula for those? Do you get creative? Like, for example, this one it's not something you normally would see. This is for a tumor case, but is there a formula that you kind of go to? Do you like to put more screws and fixation in the ilium? Do you fix the ischium? What's your method for this?
They're all different. They're all like fingerprints.
Yeah.
But I definitely like I do like big home run screws.
Where in the ilium, or where are you putting them?
Yeah, up in the ilium. The thing is, down on the ischium, a lot of times over time, I've seen some screws work out. It never seems to be a problem. They just kind of hang out in the soft tissues. But I just think that the fixation of the ilium is so critical. And that's usually where I'm going to plant my initial screws. Get that that good fixation and go right down to the ischium and just bridge that, and then just start trying to find bone and direct the screws where they should go.
Richard, where are you going for your fixation? Do you ilium, or do you want to fix it to the pubis and ischium? And
Yeah, the hardest thing to do is trying to get screws in the ischium and pubis. It's just hard for everybody. That's when custom implants help because they can sit there and guide you and it shows you where the screw goes. Other than that, you're guessing on some of these constructs. And if you don't get a screw in the pubis or ischium and then up into the ilium, they're going to eventually fail. All right. So you got to get some solid fixation somehow. People forget that, in the old days, you can do a double cup technique. We had augments. You can do Harrington type procedure, which is sitting there putting a bunch of pins up there and rebar and filling it with cement. We used to do that for metastatic disease and they last a long time. Again,
right.
for people who don't have options for custom implants, there are a lot of options and other things you can do creatively to get these done.
Well, speaking of creative, I was wondering, do you guys do any hip fusions, any pseudoarthrodesis? I was doing some of this in fellowship. This one's for a tumor case, but any indications now for fusion of the hip?
That's a really, really rare thing in this day and age because there's too many things you can do. We went through these in the old days. And remember, the Mayo Clinic was big on doing allografts and reconstruction, giant pelvic constructs. And they were great and they worked for a short time, but they all fail miserably because I teach people when you put massive allografts in there, it never heals at the allograft autograft junction of your normal bone enough to support it for any length of time. And you put massive stuff in there and massive dead stuff, it's still dead and it's increased risk of infection and problems. And so they fell out of favor and rarely is it done anymore and rarely are fusions done anymore.
Yeah.
At least in this country. We
At
see
least
them from
I think North America, yeah, you don't see a
yeah.
lot of
I
fusions.
see people come in from Mexico like this fuse all the time.
And you see less of them being out there to take down. Early in
Right.
my practice, I saw some, and yeah, we'd take them down. But
Right.
trouble is, a lot of times that musculature is pretty atrophied, fatty atrophy. So, you have to tell people their function may really not be all that great. They're going to give them some pain relief. Functionally, it may not be as great as they would like.
Hey, Ira, does any of the people have any questions?
Well,
Usually they have questions.
if they have questions, they could raise a hand or put them in the chat. I have a couple of questions. Getting back to the idea of how to avoid getting to be one of Herrick's pictures. Okay, first of all, that's the topic I'm at. How to avoid that. So I think of it in three categories, and I'm just curious what you guys think about the percentage in each one. Is it before they went to see each of you? Was it the wrong surgeon with decision making? Was it the wrong implant or was it the wrong patient? What was really the
Oh,
cause?
no, it's always the wrong patient and the wrong approach, what you did. All right. It's not the surgeon, and it's not the implant. It's the proper use of the implant. Okay. And what to do. You didn't avoid the comorbidities. You didn't do the things. You didn't plan maybe as well as you should to use what you got. You got to remember, some people don't have all the things that me and Herrick and John have available. Right. So they do the best they can sometimes, but most of the time it's the third is the patient. And again, I told you the patients don't always do what you told them to. All right. I'll sit there and reconstruct the patient, and they'll be there and come back in 2 weeks later without their brace on. All right. After you yelled at them to keep their brace on and destroy your construct. All right. And so it's number three almost always.
Well, getting
Not
back,
not always the surgeon, nothing. There's a lot of good surgeons out there. All right. It's just there are some that maybe shouldn't or trained here. And if you don't have all the things you need to treat these patients, probably need to go to a center that has that available for you.
how involved do each of you get in the whole pre-op optimization process? John, I want to start with you. How involved are you able to get, especially when people come to you from a wider geographic area?
Well, I mean, we offer nutritional supplementation. The problem is that people have to pay for it. And you can lead a horse to water, you can't make them drink protein, right? But that's I think it's one of our chief problems because we absolutely encourage it, want them to do it, and it doesn't always happen. Um, certainly we get pre-op labs, we take a look at that. And I mean, if they're in a severe malnutrition state, well, I mean, you really do have to, they have to be committed to optimization. And we have, nutritional expert in our group that does that. So that's pretty awesome. But you can only do so much, right?
Right.
And restriction of alcohol, drug use. If they're smoking, I make sure that I'll test them for nicotine, pre-op, all that stuff, and I tell them, you better not have anybody in the house that's smoking because maybe I'll even pick that up. So
Right.
anyway, it's just, you just do the best you can.
Do any of you have your own internist or pre-optimization internist in your sort of ecosphere? Maybe not your practice, but in your universe that you send these patients to, possibly? Herrick, how about at the
No, I mean, currently I'm pretty much working with their primary care doctors.
Right.
I don't have anyone that's particularly interested in nutritional other than the nutritionists, but no one specific. I think, like I was saying, a lot of the stuff we get in this realm is urgent. So we're kind of treating them without doing a lot of optimization. I think there is a lot of room for optimization between, say, a stage 1 and a stage 2 that we probably don't utilize because we don't see the patient often enough to get that involved. But I've always encouraged infectious disease doctors to try to encourage like a nutritional program for them. It'd be nice if you have that kind of support from the infectious disease.
We have a question from Esteban Hogan. Esteban, you want to ask your own question, or we'll ask it for you?
Hello, everyone. Nice to see you.
Thank you for
I'm
coming.
Esteban.
Esteban.
Esteban from Quito, Ecuador. Nice to see you guys.
Great to see you.
I was wondering, here in my country, we have a big problem that is that more of the surgeons are low volume surgeons, less than 10 replacement per year. And most of the complications and disasters, they come from this kind of surgeons. Is the same in the States, or what are your strategy to avoid that? So I can change here in my country that problem.
Funny you should ask. I think I just saw on LinkedIn. Did you guys see all that? I think it was maybe in Journal of Arthroplasty that they did a review on that, and they found that the average for, I think, most surgeons that do joint replacement in the U.S. that actually committed to do it, I think it's like average over like 190 a year. Am I wrong with that?
No, it was a little less. Some of them ran in the 100, but it was about 60% of the doctors do that, but 40% did 10 or less.
Oh, I see. Okay, so
Right.
I
So
saw it
and
on
that's
LinkedIn,
and
right?
that's sometimes a problem
Yeah.
with that, because I teach these guys all the time. There isn't one person on this panel that you guys can't call tomorrow and say, "Hey, can you help me? What would you do? What would you do on that?" There's nobody here. You can come in and see us do anything you want to do. None of us will throw you out of the OR. We don't access our colleagues like we used to. When I first started, I'd call my guys all the time and people I knew and go and learn how to scrub in and do some of these things. Because you can't just go to a course and go to Chicago and go to the academy and come back and say, "Hey, I want to try this." All right? It doesn't work. You got to see it in real time. There's a lot of things about it that you can't treat and teach. Right? And so that's when you kind of get into trouble. You got to not do things you're not comfortable with. There's people that are comfortable with some things. We talk about approaches. I don't care if you do an anterior approach. I don't care if you. I'm the chief, and they come to me and said this guy took 4 hours to do their surgery. You need to go talk to him. I asked, well, did you do it right? Okay, because if he did it right, okay, all right, I'm sorry, all right, I'm not going to do anything about that. He'll get better a little bit over time. If he didn't do it right and it took a long time, well, then I got to sit there and have him scrub in and do things. So sometimes you have to. You're not being mean, but sometimes you have to reach out and say, "Hey, why don't you come over here and scrub with me? Learn how to do these here going forward." You got to reach out to your guys, and they got to be smart enough to do that. But I don't want to complain about the young generation, but you guys are afraid to ask for help. Us senior guys have a lot of knowledge of things we screwed up. You can learn how to maybe sometimes not screw things up by talking to us because we all screwed things up.
Yeah.
You guys think we're going to see less disasters in the future with new implants, new robotics? Is this something that could be in the past? Will the implants fail as badly as the implants from 10 to 15 years ago? Are we going to be dinosaurs and be extinct from disasterplasty?
It's a
So
great
Esteban, I mean, all you have to do in your society is try to teach these guys and help and have courses for them. That's all you can do. But you can't stop these guys from operating because it says MD after their name.
Yeah.
Yeah, that's right.
We have some more questions.
Yeah,
Ira.
there's John Desjardins. You have a question about lavage?
The Gerald.
What?
Yeah, John Gerald, he's got a question. Yeah.
All right. Well, his question was about lavage work in revision primary settings. Is there any go-to lavage that you guys use? And then also a question on intraosseous with Vanco.
Okay.
I,
Anybody, you guys want to tackle that or want me to do
I
it?
think everybody has their own
Yeah.
lavages,
Right.
and there's some good ones. There's the betadine irrigation. I use Back to Sure. I use BioWash. I do have an interesting comment about this intraosseous vancomycin, and I know there's some dude in China, and he talked about it at ICM that has great success. The thing is that we're all worrying about biofilm, and I just have concerns about just throwing antibiotics at stuff that won't penetrate through biofilm. I don't care if it's even if it's a new antibiotic that's going to be out on the market. If it doesn't bust through biofilm, it typically only works on planktonic free-floating bacteria. So that's why antimicrobial solutions, antiseptic solutions may be the key to success for this management. I don't know that we're ultimately there yet. I mean, I wish we were. I wish we were. Yeah.
We're getting there. Some of the bio washes and things help prevent biofilm. They just don't stick around long enough. The one that sticks around the longest right now, I think, is phase one that's out there. All the other washes John uses, I've used, I'm sorry, Herrick used. And betadine is still the time-honored cheap way. If you don't have anything, you dilute it at least 0.5%, a little bit more. Let it sit there for 3 to 5 minutes. I still remember going over in England and watching them operate. They had an infection. They put a beta in, close it, and then they go have lunch and then come back and operate and let it sit there for a while. And
Sounds
so
like a great idea.
yeah, those things work, but we're not to the point the other. We keep going through these things about antibiotics. First, you can put antibiotics in the wound and the trauma guys, and they said, don't do that, it's bad. And then all of a sudden it's okay. Now you're putting it in the medullary. All right, no one can tell you for sure it's not going to do anything. That doesn't make any sense. If you're already doing antibiotics, you put antibiotics in the cement and you're putting it in medullary already, or you're reaming it, it's going to get in there anyway. So putting it in there doesn't make any sense to me. Just put it around the prosthesis and implant at the end. It does pretty much the same thing, in my opinion.
Hmm. Hmm.
Awesome. So we have one more question, and then we're going to call it David Lazinski. You want to ask your question? You have a plastic sperm comment on nutrition, if you're around, Daniel.
Really enjoyed the conference. Great insights, Dr. Bush. Really agree on your comment on interval fusion, because if you have something driving inflammation, be it mechanical motion or unstable wound, you can't progress to healing. So it makes a whole lot of sense. Just two brief comments. There's an antidote to chronic steroids. It's oral vitamin A. It's good general surgery data that's many decades old. I've used it dozens of times in my practice. A lot of orthopods don't know that. I wrote it in the chat just for those of you who never heard of it. It doesn't antagonize the beneficial effects of on the steroid as far as controlling the COPD or the arthritis, but it does reverse the healing impediment that's imparted by steroids. Just one other comment from the burn unit. We would wait until their acute phase markers are anabolic. So instead of having to wait a full 4 to 6 weeks for something like an albumin, pre-albumin has a 2-day half-life, transferrin. Once they start ramping up and they're starting to be anabolic, then we would skin graft them in the burn unit because if we make the wrong decision, skin grafts will fail and they could die, in the big burn. So it's not so much that they got to get to a normal albumin or anything like that, but if they're starting to trend up, that means they're starting to be anabolic and you can operate.
Great comment.
Thanks.
So we are over in what is affectionately called the fastest hour in orthopedics. I do want to thank the panel, Richard, John, and Herrick. I would like each of you to make some final comments. So we'll start with John, go to Herrick, and Richard, you'll bring us home.
Well,
John, final
kind of,
comments?
to kind of bring up what Herrick mentioned earlier, there is no way that somebody that does revisions is going to go out of business. There's too many surgeries. Our patients are too complicated. They're too sick. We're operating on too young individuals frequently, and sometimes just bad things happen to good people. And so, trust me, there's going to be a lot of work left around for us, and it's very unfortunate. But those are just the hard facts. So that's all I got.
Herrick?
Yeah, I like the idea of getting other opinions. I'd have your network of people, particularly if you're doing revisions or seeing complicated cases. I talk to these guys that are on the panel. I talk to whoever will listen to me about my getting another opinion. I like to hear from other people. So I encourage everyone to, send your patients for second opinions. Most of the time they'll come back to you. They kind of respect the idea of getting more input. I think it also makes them more comfortable on whatever decision's about to be made. And I do use that expectation, trying to give them a percentage of what I think the outcome may be for them. And I think they can understand a number better than me telling them, well, this may or may not work. We'll have to see, because that doesn't really give them. But I'd get, look at the expectation of what they want from this and treat the problems early and try to get the person that's seen this before involved with the with the plan.
Richard, you want to bring us home?
Yeah, I'm disappointed Spencer Montgomery didn't give us any question.
I'm here. I've got family.
There he is.
all
He's just an
over me,
ass.
so
there isn't anybody in this country at any major institution that I can't call tomorrow and they'll call me back and I can pick their brains. All right. There is nobody here that's on the panel tonight that we haven't talked and said, hey, did you see this? You ever do this? What would you do on that? All right. Because ideas help. Stop thinking you're the smartest person in the world, because you're not. I'm not. Herrick's not. And things. Sometimes a different approach to look at something is very helpful. Stop being afraid to go ask for help. Right? There's nothing. It's not a sign of weakness at all. Right? But we'll talk about these things, and you guys, if you can, come to Disasterplasty. We go deep down into a lot of these things. We have a lot of arguments and a lot of fun going. It's not a meeting you've ever been before. It's if you can't enjoy yourself, then I'll give you a refund. Right? Because we have a lot of fun there. No, you're not getting one.
Yeah. Well, I went last year and I didn't need a refund because I enjoyed it. It's a great meeting. And I'm very glad we got a chance to showcase that tonight. I want to give my sincere thanks to the Disasterplasty team. I can't wait for the course coming up. Had a great time last year, learned a lot. I think people need to register now. And I want to thank all the panelists and thank everybody for coming and say good night.